Today I'm talking, this is a piece of research that I was involved in alongside Christine Conception, Jessica Botfield, who's an amazing nurse, Serena Lacey, who's a researcher, and Kevin McGeechan, who's a researcher. Jane, Deb and myself are part of the senior management team at Family Planning New South Wales. So we looked at the cost-benefit analysis of increasing access to long-acting reversible contraceptives. So that's IUDs, implants. Depo-Provera, the needle for contraception, is technically a long-acting reversible contraceptive, but we don't tend to talk about it in the same context as we do with IUDs and implants. So we wanted to look at how we could increase accessibility by including nurse-led insertions. Now I've got a little button here. Okay, so what are LARCs? LARCs are long-acting reversible contraceptives. They're highly effective in preventing pregnancy. They're as effective as permanent methods in most of the cases. Unfortunately, the uptake of LARCs in Australia is very low compared to other countries. So in combination, LARCs are down at about 12.5% of Australian contraceptive users, in comparison to 33% of oral contraceptive users and about 30% condom use. So, I mean, if you think about your oral contraceptive pill, they're about 98% effective typical use. Your condoms are down about the 7 to 8%, and your LARC methods are up about 99+%. So, if we had women using a lot of long-acting reversible contraceptives, our unplanned pregnancy rates would drop. So, what did we do? We did a cost-benefit analysis. We wanted to look at the impact of two different scenarios on the cost of contraception for Australian women over a 5-year period. So, we looked at women switching from oral contraceptive use to a LARC method, and we also then looked at women starting a LARC method when they haven't been using any prescribed contraception before, so using natural methods, withdrawal method condoms. Both of these scenarios had a couple of assumptions. They assumed that the proportion of women that would change to a LARC method would be the same as comparable countries, so about 14.8%. I think that number comes from countries like France, Germany, Spain, Switzerland. In addition to the impact, in addition we then looked at the potential impact of the increase in LARC insertion removals and insertions being carried out by registered nurses in comparison to GPs. So we found that women who switched from an oral contraceptive to a LARC would realise an annual cost saving of between $114 to $157 per year, depending on which contraceptive they were using. Obviously there's some pills that are $20 for 4 months, and there's some that are $90 for 3 months. So that's where that difference in cost comes from. We looked at women adopting LARCs from a non-prescribed method, so that was using your condoms or your natural methods, and they would incur costs, of about $36 to about $194 a year in that first 5 years. So if women on the pill changed to a LARC method in line with the comparable countries, so going up from our sort of IUD use on its own is about 6% use of that 12.5% of LARC use overall. So if women change to go up into that 12.8%, then the net savings would be 6 to 8 million over 5 years. Okay, hang on, I've lost where I am on my bits of paper. So we then looked at women who were not using a prescribed method and who could then adopt a LARC method. The value of avoiding a termination of pregnancy or a miscarriage for those women would be about 20 million over 5 years. Sorry, I've lost myself. Everyone else is really professional. I've gone blank. Okay, so if about 20% of women who switch to a LARC method are seen by a registered nurse in comparison to a GP, there would be an additional cost saving to the government of about 2.7 million over 5 years. So that's in addition to the cost savings that women are going to have as well. Additional savings for the women for the lower out-of-pocket costs for nurse insertions are about 500,000 over 5 years. We are trying to advocate for nurse item numbers on the NBS to be able to insert IUDs. LARC use in Australia is really cost effective for both women and government. Nurse-led IUD insertions can lead to additional cost savings for the government and for women as well, which is really important. Our findings could help support women in making informed decisions about contraceptive methods that are right for them. A lot of women come and talk to nurses about which contraceptive method is. I mean, that's my bread and butter, is helping women to make those decisions. And to be able to help someone to make that decision, to then assess them for their medical eligibility, and then see them again and put that IUD in and know that they've now got a method that's going to protect them for 5 years, 10 years, it's a great feeling. We also think that these findings can support the efforts to increase the accessibility of LARCs in Australia, and trying to advocate for MBS item numbers is the next step along in the way. That was very dry, sorry. Does anyone have any questions?
So what do we need to do to get the government to let nurses do it? To
Well,
place IUD?
so my next talk is, and that's my research, which is a bit different. But my next talk is, we have at Family Planning been doing nurse-led insertions for since 2012. So what's that? 6 years. And also Family Planning New Zealand have been doing it for a lot longer than us. So we modelled our nurse-led IUD service through the Family Planning New Zealand. They actually came over and trained us and talked with us and showed us what their model was. So I think the next steps, first we've got to prove to the government that it's cost effective and comparative care, that we're not giving any less service, and then we've just got to keep getting the message out there, hence I'm here today.
Have you had any grievances from anyone? Have you had anyone saying, no, we don't want nurses doing this, it's not your place, that kind of thing?
You'll see, interestingly, in the next topic, that was something that we as nurses were pretty worried about before we ever started doing the IUDs, but I've never once had any sort of feedback like that from any clients, from any doctors. I mean, I was one of the initial people to be trained as part of this study, and I now train doctors in IUD insertion and nurses in IUD insertion, and I've never come across any of that kind of, you're not good enough or your skills are different. You know, it's a trained skill, and if you're trained to do it well and you're capable and you're competent, then it's a really good skill to have, I think. Yep. Yeah. So Family Planning does offer IUD insertion training. We do offer it to nurses and doctors and nurse practitioners. You can do it also through the other family planning associations and Family Planning New Zealand as well. What we do have to clarify for nurses that do want to come is that they've got organisational support and management support and indemnity cover. So that can be the trickier part, but we try our best to help people to get those get them on that track and on that pathway of getting that support in place for them. Yeah. It is a 4-hour session, like a theory, and there's a theory module to complete, and then you do, I think, 3 sessions in the clinic of supported practice, and that's for nurses or doctors. It's the same. I'm not sure of the price, if that's the next question. Anyone? Any more questions on that one? Our organisation has organisational indemnity, which covers our nurses, and that's the track that most places would tend to go down that track if they were doing it. Personal indemnity, you just have to call and ask, call around. I know APNA's doing some personal indemnity insurance at the moment because I've been chatting with them. Yeah, but you'd have to have procedural indemnity, which can make it a little bit pricey.